Hello, everyone, and welcome back to the Oncology Brothers podcast. I am Rahul Gosain, here with my brother and co-host, Rohit Gosain. Today, we're thrilled to bring you an exciting episode focused on early-stage non-small cell lung cancer. We've covered this topic last year with Dr. Charu Agarwal, and it is amazing to see how much has already changed over the last 12 months in this space. Today, to help us reiterate the current standard of care and focus on some recent advancements in early-stage non-small cell lung cancer, we're honored to have Dr. Patrick Forde from the Johns Hopkins University with us. Patrick, welcome.
Thanks very much, Rahul, and good to be with you both. I'm looking forward to the discussion.
Well, thank you so much, Patrick. Let's dive right into this algorithm. We know that for stage 1A, the choice is surgery or SBRT if these patients are not surgical candidate. While beyond that, that is stage 1B and beyond, this space is changing by the minute, which is, again, a good problem to have. Now, if we are to present a clinical scenario here that is outside of clinical trials, patient with no actionable mutation, for stage 1B and beyond, if this disease is resectable, what are you doing in your clinic, or what does the tumor board conversation looks like? Whether are you relying on neoadjuvant nivo with chemo based off your study, Checkmate 816, or would you rather entertain periop IO combination with chemo followed by IO in post-op settings?
Yeah, I think, Rohit, it's kind of a very much an evolving space at the moment. My personal preference is that if the patient is a candidate for perioperative chemo, be that neoadjuvant or adjuvant, then I tend to favor doing it in the neoadjuvant setting for a few reasons: tolerability, completion of therapy, and also this kind of theoretical, but I think increasingly supported idea that neoadjuvant immunotherapy, either in melanoma or perhaps in lung cancer, has some advantage over adjuvant immunotherapy. And in the absence of mutations, you're generally looking at immunotherapy as being the main driver of benefit here.
Absolutely. Patrick, thank you for setting that foundation. So coming back to this hypothetical patient in front of us, in this scenario, our options are a neoadjuvant nivo chemo or pembro with chemo. And then, of course, you have other options for periop, immunotherapy, and chemotherapy as well. How are you picking your treatment options for this particular patient in front of you?
Yeah, it's a little bit of the reason I say we're in flux is that there's a couple of regimens still under review by the FDA with PDUFA dates this year. So both, I think the durvalumab chemo combination perioperative and the nivo chemo perioperative regimen they're both due decisions this year from the FDA. But at this very moment, the two approved neoadjuvant or perioperative regimens are Checkmate 816, so neoadjuvant only, or Keynote 671, which is perioperative.
Uh-huh.
I don't have a strong feeling, to be honest. I tend to favor chemo nivo for these patients just because of experience. The results have continued to be kind of encouraging. We had 4-year follow-up recently, but I also don't think it's wrong to consider the perioperative regimen in the recognition that probably 70-75% of the patients will get to the adjuvant setting. Maybe 40-45% will complete the full perioperative course. So it's not that you're committing a patient up front. You're definitely going to be here in a year still getting pembrolizumab. You're probably not going to be still getting the pembro at the end of a year, but you may get more immunotherapy, and there may or may not be benefit to that.
Absolutely. While we were talking about this, Rohit, you started off by saying no actionable mutation. I think it's important to reiterate one big thing here for our listeners. It is critical to get NGS testing even in this early stage now, because we have osimertinib and alectinib for our EGFR and ALK positive patients. And also these patients do not respond to immunotherapy, so exposing them to neoadjuvant or periop immunotherapy would perhaps be the wrong approach. We'll come back to this, but Patrick, you've alluded to this. In clinical practice, we run into two scenarios that baffle us. A patient that receives neoadjuvant or periop treatment, but is unable to go through surgery. And we continue to see this number is significant, even in clinical trials. So in the real world, that's a lot higher. Or the other scenario where they get treatment and they go through surgery, but they don't have a significant response. Can we start off with a patient in your clinic that receives neoadjuvant nivolumab and chemotherapy or periop chemoimmunotherapy, but is unable to go through surgery? What next?
Yeah, I think it's a tough scenario, and I think some of the what next question is based on the patient selection up front, because if it's truly that the patient had occult, say metastasis, for example, pleural disease discovered at surgery, then we're probably heading down a metastatic disease paradigm. However, if it's due to kind of unexpected surgical unresectability, despite a response to therapy, that's a second scenario. And in that scenario, you might really be thinking of definitive chemoradiation. So if it's a scenario where the patient has not had distant metastasis develop, has perhaps locally unresectable disease, then I think the most likely course for me would be definitive chemoradiation. You've already given them systemic dose chemo with the neoadjuvant, so I would probably do something like carbotaxol with radiation. And then post that chemoradiation, you're probably going to end up giving them more immunotherapy with durvalumab. On the other hand, if they didn't have surgery because of progression, that's a much tougher scenario, I think. And I have had a few of those patients in that scenario, which is a very tough one to deal with. If they've developed distant metastasis during the course of neoadjuvant therapy, I think that's a bad situation. And
Rahul, another scenario that we tend to see commonly in our clinics, and I'm sure Patrick is the same in your case, is you go with the Checkmate 816 neoadjuvant treatment option. Now, this patient had partial response or rather very little response to the treatment, and they do undergo surgery. Then, after that, any role of adjuvant treatment here, especially when they didn't have too much response?
Yeah, I think that's perhaps one of the rationales for the perioperative approach is that you keep open that option. Now, in practice, it's probably still an option to give adjuvant in that scenario, assuming they fit the criteria for adjuvant pembrolizumab or atezolizumab. But I think the only data we have to guide us really are these subset analysis within Checkmate 816, within Keynote 671, looking at those patients who had either a PCR or an MPR and those who didn't, and how they did long term. And there was a suggestion from Keynote 671 that there was quite a good difference in the non-PCR tumors in terms of disease-free survival for those who received pembrolizumab. The same in Checkmate 816 to a lesser extent, probably, and also perhaps in Checkmate 77T, which is the perioperative chemo-nivo. In that publication, they did a landmark analysis, which was published in the New England about 2 or 3 months ago, but a landmark analysis at the time of surgery looking at pathologic response and receipt of adjuvant therapy. And in that landmark analysis, there was a suggestion of benefit for adjuvant therapy in both pathologic groups. So I think I would definitely discuss with this patient doing further immunotherapy, explaining to a degree that we don't have really good prospective data saying it'll be beneficial, but I think it's a reasonable option if the patient is otherwise healthy and hasn't had a serious immune toxicity.
Perfect. And Patrick, you started off by saying we continue to see this paradigm shift where we're exposing patients or the tumor to immunotherapy upfront in neoadjuvant settings. Melanoma continues to lead the pathway here. We saw that at ASCO plenary. But if for some reason patient did not receive neoadjuvant or periop treatment and goes for upfront surgery, now in adjuvant settings, we have chemotherapy with known overall survival benefit with cisplatin-based regimen. But even here, we have pembrolizumab and atezolizumab approved. Patrick, in this case, your preferred immunotherapy, and are you using PD-L1 score here to dictate that choice?
I am to a degree. I think it's so as you mentioned, we have a PD-L1 agnostic approval with pembrolizumab in the adjuvant, and we have a PD-L1 specific approval with atezolizumab. I think where I'm most comfortable giving this is in the PD-L1 high group, 50% and above, because it was pretty clear from Empire 010 with the atezolizumab that there was a lot of benefit for those patients, and probably even an overall survival benefit with PD-L1 50% and above with the tezo. So I do tend to, if I see that, I will generally go for a tezo. In the rest of the group, I think it's a more nuanced discussion because the data with pembrolizumab was kind of cognitively some dissonance there between PD-L1 high, perhaps not deriving benefit, but PD-L1 less than 50% and zero even deriving benefit. So I try and, depending on the patient's health literacy and their ability to take on board these things, I try and discuss that with the patient, and also the fact that there's a small but real risk of some serious immune-related adverse event. I had a patient recently getting adjuvant pembro, thankfully had PD-L1 high disease, so I was a bit more comfortable, but developed type 1 diabetes while on the therapy. And that's usually kind of irreversible. So it's not inconsequential that you'll have maybe 5-10% of patients over that year will have some serious adverse event. And that's something in the adjuvant setting that I think it behooves us to discuss with the patient and just explain that risk, so we're not dealing with the consequences without them being aware of it up front, you know?
Absolutely.
And thanks for stressing that, because we in community are very much used to immunotherapy, but again, this has real side effects associated with it, so we have to still use it with caution. Patrick, before we move into the unresectable space of stage 3, it is important to touch on osimertinib and alectinib in resectable disease. Rahul, you mentioned the importance of NGS testing, and that is extremely important before exposing any of these patients with systemic treatment. Patrick, if a patient with either of these mutations was to go for surgery up front without any neoadjuvant treatment, in terms of discussing the adjuvant treatment options, would you rely on chemotherapy adjuvant and then start them on oral agent? Or if the patient is not willing to go for chemotherapy, are you comfortable starting these patients on oral therapy?
Yeah, so I think you phrased it well there, Rohit, in that there is probably the data, so you can use it to justify either approach, really, I think. My personal preference, most of the patients with EGFR mutant lung cancer or ALK fusion positive are usually pretty healthy otherwise. And they're usually patients who could theoretically tolerate chemotherapy. And historically, these have been tumors which have been pretty chemosensitive in the advanced disease. We forget about this, but ALK positive disease is pretty sensitive, for example, to pemetrexed-based platinum doublet. So is EGFR disease. So my personal preference is still to offer adjuvant chemotherapy, in recognition, though, for example, that the ALINA trial that led to the approval of alectinib did not have chemotherapy in the alectinib arm. But I think there is probably some survival benefit there, and there's also a proportion of patients who may be cured. There's no reason to think that historic 5% benefit we've quoted for adjuvant chemo doesn't apply to these patients in terms of long-term cure. Whereas there is still a debate as to whether targeted therapies like alectinib or osimertinib are really kill cancer cells, or do they eliminate tumors, or do they put them into prolonged stasis? So my personal preference is chemo followed by targeted therapy, but I think I would not push a patient too hard if they decide not to, if they're pretty definite they don't want to do chemo, you know?
Patrick, I'm actually going to just tag along with the same idea you brought up, that these targeted agents perhaps might be pushing our patients in some sort of remission rather than cure. A patient with osimertinib after 3 years, once they're coming off this treatment, are you monitoring brain MRI more frequently than you would otherwise? Because we've seen high CNS recurrence after stopping osimertinib in this patient population.
Well, I think what we've been doing here, at least, is once a year. We've been doing a brain MRI in these patients. Now, sometimes insurance will have difficulties with that in the absence of known brain metastasis, but where it's possible and feasible, I think it makes some sense. Because one possibility there is that you capture an oligometastatic state and you can treat it with SRS, for example. So I think in both of these settings, it is something we are thinking of. Particularly if you do stop at that 3-year mark. And I know some of my colleagues are continuing on the osimertinib. We haven't got too many patients that far out, but we do have some now. I think that'll be an interesting long-term analysis, and I think we may have to rely on kind of real-world data quite a bit there to see what the outcomes are internationally. Some countries you cannot continue on past 3 years, so I think the data from those countries where it's kind of mandated by the health system to stop at 3 years will be interesting to compare, say, for example, with US data.
Yeah, this is especially a hot topic now after Laura study where osimertinib was indefinite. But before we jump on Laura, while we're on the topic of actionable mutations, given we're testing these whole lot more, we're going to see other actionable mutations like ROS1, BRAF V600, or even uncommon EGFR mutations. Patrick, any clinical pearls for these mutations in resectable disease?
Yeah, I think it's a really tough one. I've had a few patients. So, for example, with EGFR exon 20, where we have increasingly effective therapies, at least in trials, and some approved therapies in advanced disease, but not necessarily drugs you could move easily into early stage, like, for example, amivantamab, unless it becomes, for example, a sub-Q version, I think would be difficult to give to people. At the moment, we're still trying to look for trials for them. I think it's hard to EGFR exon 20, for example, PD-L1 negative disease. I think it's hard to recommend for that sort of a patient adjuvant immunotherapy, given we know it probably doesn't work well in advanced disease. So in those cases, I do tend to look for trials. If no trial, I probably just stick with chemo, unless we have some adjunctive evidence to suggest that immunotherapy might help. We haven't really been extending our adjuvant targeted therapy experience very far past alectinib or osimertinib. We have had some discussions in our group, for example, for RET, where it's the one patient a year or two patients a year who have surgery, kind of in that scenario. But we have not. It's been very debatable, and we've no real data. So it's a tough one. I think it's a regulatory question as well, because it's going to be hard to do randomized trials in these scenarios.
Right, and again, we'll have to wait how these studies play out, but as of now, osimertinib and alectinib are the only adjuvant targeted therapy options available. Now, switching our gears into unresectable disease state, which is still stage 3, historically, we have made an argument that our treatments really making major difference from curative intent, though we are treating them for curative intent, but we are always worried about this micrometastatic disease presence here. Based off of the Pacific trial, we have been treating these patients with concurrent chemoradiation therapy in the absence of any actionable mutations, and followed that with durvalumab consolidation. Any role particularly of PD-L1 score in your practice to dictate the consolidation durvalumab here?
No, to be honest, I don't tend to use PD-L1 too much. Where I do use it sometimes is if a patient is a very borderline candidate for durvalumab, if they have, say, lung disease, quite poor lung function, and the tumor is PD-L1 negative. So that might push me to discuss with them not doing durvalumab. But otherwise, if all else being equal, I do recommend it. In Europe, the European Medicines Agency only approved durvalumab for PD-L1 1% and above. That was based on a kind of retrospective subset analysis, which didn't unfortunately have results for all the patients. So I think there's a lot you could criticize based on that decision, but in most European countries, durvalumab is restricted to PD-L1 1% and above. And I think what we can discuss with our patients is that if it's PD-L1 positive, there's probably quite a lot of benefit. PD-L1 negative, likely less, but perhaps some residual benefit. And if they don't have a clear contraindication to durvalumab, I will recommend it,
Yeah. Right now, consolidation durvalumab in most cases after concurrent chemoradiation remains the current standard of care, as we've seen overall survival updates that continue to favor durvalumab. Okay, then on to Laura trial from this past ASCO 24, ASCO lung. Patients with common EGFR mutations after concurrent chemoradiation received osimertinib. We're seeing a significant PFS here, but this was lifelong therapy. Patrick, your thoughts here?
Mm-hmm. Yeah, I think this is a very interesting situation, because if you looked at the Pacific for all comers, probably about 40% of patients in Pacific are cured effectively, or they're still progression-free at 5 years. So in Laura, however, in the control arm, I think it's something like 13% are progression-free, so much, much lower in the EGFR mutant population. And there was a subset analysis by Jaruska Naidu from Pacific as well, suggesting that the EGFR group did not derive benefit from durvalumab. So I think here we're in a kind of a tough situation. There likely are some patients who are cured with definitive chemoradiation alone. I don't think durvalumab adds anything for EGFR mutant lung cancer. But the big question is, what do we do? Do we commit a patient to being on osimertinib potentially for the rest of their lives, which could extend hopefully 20 years, So it's a very challenging one. I discussed this actually at ASCO. I was one of the discussants in the highlight section, and so I think you have to have an open discussion with patients, and I think there will be some patients who will probably decide not to do the permanent osimertinib and perhaps see how their disease goes over the first few months. We also don't know whether if you start it immediately, whether that's better than starting it at the time of progression. So those are all things I would try and bring up with the patient. Personally, I think if you're probably better off starting it earlier, but I don't know that. And perhaps in the future we'll have kind of additional tools like ctDNA or liquid biopsies, which might help select out those patients who are really deriving the benefit.
Absolutely.
From osimertinib. I would also have a somewhat lower threshold in this setting to dose reduce osimertinib for tolerability, because I think we want patients to be able to tolerate it as well as derive the benefit,
Absolutely.
Right. The advantage is that it's an oral medication and generally very well tolerated. But again, it's always a debate about over treatment versus under treatment. Now, in a very similar scenario, Patrick, if you had rather an ALK mutation in stage 3 unresectable patient, though we have convincing data from LAURA trial for osimertinib, but for ALK mutation, what exactly are you doing? Of course, we know durvalumab doesn't really benefit here either, but again, maneuvering through this landscape here.
Yes, so I think this is one situation where so at least in our group, we've started to extrapolate from the resectable setting to the stage 3 setting, and really because the resectable data with Alina is so positive and the risk of relapse is very high in the control arm there. Our assumption is that even in a higher risk group like stage 3 disease, there has to be some benefit from consolidation alectinib, and that's what we've been doing over the last year or so. We've moved towards definitive chemoradiation, and then, where possible, an ALK inhibitor, without a lot of randomized data, I have to admit that. But I also would have concerns in this setting, particularly about development of CNS disease with just chemoradiation. So that has been our general practice. And deviating, I will say, from the approvals, but hopefully we'll get more data in the future on that.
Right, we have adapted that in our community practice as well, but again, it all depends on the insurance approval as well. But again, there's so much happening here in this particular space, and the onus is on us as community oncologists to keep up with all this, so we can provide all these options to our patients closer to home. Patrick, thank you so much for covering all this today with us. For our listeners, let's do a quick recap.
Today with Dr. Patrick Forde from the Johns Hopkins University, we had a chance to cover the current standard of care treatment options for early stage non-small cell lung cancer. Before committing to neoadjuvant or periop treatment, it is critical to ensure that our patients do not have any actionable mutations.
In this discussion, we have also highlighted different available options for resectable non-small cell lung cancer, including nivolumab with chemotherapy based off of CheckMate 816, or perioperative treatment with chemoimmunotherapy and then post-op immunotherapy. We also touched on stage 3 unresectable non-small cell lung cancer space with durvalumab being the current standard of care as consolidation, and osimertinib based off of recent data from LAURA trial at ASCO 2024. Thank you for tuning in. Make sure to check out our other discussions in lung cancer series. We are the Oncology Brothers.